afternoon, good evening to everyone who's joining us. We welcome you to the third regional international meeting. We're focused on the Africa region today. My name is Parvati Krishnan. I am from Global Genes. It is my distinct pleasure to welcome you all to this panel discussion. Thank you so much for taking time to join us. Before we get kicked off, I wanted to review a few brief housekeeping notes. The chat box to the left of the video allows you to interact with each other and program staff, and we hope you use this opportunity to make some new connections. Please note that links and resources are not to be shared via the chat. If you would like to upload any shared resources to the community, please share those on the social wall. The questions box is located to the left of your screen. We encourage you to use the questions box to share your questions with the presenters. This is your time to find answers and insights to help you advance your work as a partner in research. Please note that the speakers will not be able to see your questions entered in the chat area rather than the official questions section. If we are not able to address all of the questions, we will do our best to follow up and connect you with the speakers. To the right of your videos, you will see captions and translations. To utilize either, please expand the session and select your language. If you have any questions about the technology of the program, please look for the request support button in each session of the live support chat in the bottom right corner of all non-session pages. And now to begin the panel discussion, it is my pleasure to welcome Professor Laura Bloom as our moderator. We may not have enough time in our session to share all the accomplishments of our moderator and panelists, but I would like for Laura to kick off with a self-introduction and take it from there. Over to you, Laura.
Thank you so much, Parvati. It's an absolute pleasure to be moderating today. My name is Laura Bloom. I'm President and CEO of the Ehlers-Danlos Society, and I also serve as a Global Strategic Advisor for Global Genes. And I'm an academic affiliate professor of practice at Penn State College of Medicine in patient engagement and global collaboration. So I'm really excited to be part of this conversation today. And I'm joined by some fantastic panelists. We have Kelly du Plessis, who is the CEO and founder of Rare Diseases South Africa. And we have Christine Mutena, who is the co-founder of Rare Disorders Kenya. And we have Samuel Agyei Wiafe, who is a clinical psychologist and the executive director of Rare Disease Ghana Initiative. And so I'd like to turn to each of them for them to tell you a little bit more about what they do. So Samuel, can we start with you, please?
Thank you, everyone. Good afternoon from Ghana. Good morning and good evening, wherever you are. My name is Samuel Wiafe, and clinical psychologist at Ghanaian Municipal Hospital. But I'm the executive director and founder for the Rare Disease Ghana Initiative, which is a non-profit organization leading advocacy and coordinating care for persons living with rare diseases in Ghana. And our mission is to improve the well-being and the quality of life of persons affected by rare diseases and their families. And we do this through education, training, advocacy, patient care support, community building and engagement, and it's providing support for research and developments. And so, yeah, that's what we do.
Thank you. Thanks, Samuel, for being here. Christine.
Good evening from Nairobi, Kenya. Christine is my name. I'm co-founder of Rare Disorders Kenya, a patient-led organization that creates awareness and basically fights for the rights of those living with rare diseases in Kenya. Personally, I am a mom to 2 children with different non-related rare conditions, hence my passion for rare diseases.
Thank you so much. And Kelly.
Thanks so much. Thanks so much for the opportunity to be here. I am tuning in from Johannesburg in South Africa. I am the founder and CEO of Rare Diseases South Africa, and we focus largely on patient advocacy through patient navigation, community engagement, And newly, we've just taken on research as a fourth strategic pillar as well, which we're super excited about. And the organization was started from my own personal need of the diagnosis of my son with a rare neurological neuromuscular disorder called Pompe disease. And at the time of his diagnosis, there was no support available for rare disease patients, and there was also no access for those needing molecules that were very, very expensive and innovative. And that is how our rare disease journey started.
Thanks so much, Kelly. Okay, so I want to hear more about the kind of landscape at the moment for each of you in your country and what it's like to try and get a diagnosis of a rare disease. So Samuel, could you share with us what it is like for someone living with a rare disease in Ghana, and how that is, and do we see the same kind of long diagnostic odyssey that we see elsewhere? And just to remind you to unmute, I'm sorry. Thank you.
Thank you, Lara. I will approach this particular issue from my personal story as to how I got into the rare disease landscape. And being a clinical psychologist in the clinic, seeing patients every day with mental health needs, I came across this family living with an unknown syndrome, and the family were going through a hard time trying to figure out what was wrong with them. And this struck me to begin to explore the systems and to identify where the gaps were in terms of rare diseases and the challenges that family go through, and trying to figure out how we could bridge these gaps. And so generally for many rare diseases, there is a general lack of awareness, and I'm sure that cuts across different jurisdictions, but specifically in our part, it also exists that many clinicians, many policymakers, and almost everybody seem not to be aware of rare diseases and many rare diseases, and that exists across, as I explored, from different perspectives, including people that you expect should know based on the work they do, and you realize that it's a silent issue. Nobody is talking about it, and nobody is actually giving attention. So that has been one of the gaps that we saw. The other issue that we saw was the fact that the infrastructure to even diagnose wasn't available. And so it also had to be something that did not motivate clinicians to even want to explore, because if you even suspect, you don't know where to go to get your diagnosis. And it was a huge challenge for a family who may have a rare disease and may not have the labs, the services, including genetic counseling and other supportive services that may be available to aid in getting diagnosis for that family. So I would say that it basically didn't exist. It was a silent issue. There was not little that could be done able to find diagnosis. Unlike other jurisdictions where there may be one or two research projects that may be going on that could even help to potentially find diagnosis. Such researches were not going on. There was the H3 Africa project, and that had focused more on the kidney diseases and other diseases, and largely neglected the condition that was of interest from the H3 Africa was sickle cell disease, and that was the only genetic disease that they were doing some studies on. And sickle cell disease is very common in our part, and so getting diagnosed for sickle cell isn't so difficult. But other rare diseases extremely difficult because of the lack of infrastructure that exists. And the cost diagnosis was also another challenge we saw. The few services that were available, say, even the imaging testing, the imaging, doing the x-rays, doing the echocardiograms, doing the CT scans, and all of those are not covered by the insurance, and patients have to pay out of their pocket, and these are extremely expensive tests. And the few private labs that could do some testing that they may not be able to do exome or whole genome or do some very complicated genetic testing, but they could do something like a microarray or do a karyotyping for a particular condition. These tests were extremely expensive, and the families that we had, majority could not afford these tests. And so the cost was an issue, the service availability was an issue, and awareness on the part of the clinicians and a general awareness on the part of even the general public wasn't there. And so these were some of the gaps that we found. Aside that, we also saw that families' mental health and mental well-being were worsened because we also have a deep-seated sociocultural beliefs about things that are unknown to us. And so we begin to make some negative stereotypic interpretation and negative belief systems around or interpretation to diseases that are unknown, and begin to ascribe meaning, including thinking that these families are cursed and it's a punishment that on these families. And these also happen to worsen the journey for these families and makes it very difficult. This was also, and so the longer you keep getting a diagnosis, the more you are going to be traumatized within the community. And that was another challenge that we found. But from a system perspective, we saw that the care was fewer of the care that were available have been centered in the urban areas. And so families who live in rural communities are not able to come, or they have to spend more to come to the urban communities, which is Greater Accra region or other regions that are more developed to get the care, and they have to spend more time. And so those who are working cannot keep a steady job or anything. So it just interrupts every aspect of their life and makes it very challenging to have a rare disease in our side.
Thank you for sharing that. Yeah, I mean, so many complexities that go into it, and I'm sure as a result there are a multitude of thousands undiagnosed. Christine, do you find similar? What kind of issues do you know that people are facing to get a diagnosis?
Actually, we have a lot of similarities with Ghana, and you find that things like costs, social cultural differences like witchcraft, something as basic as maybe your parents didn't finish paying dowry, so that's why your child is like A, B, C, D. Things like genetics. We don't have genetics as a discipline yet. I think we only have one pediatric geneticist, and genetic counseling is done at the point of the lab, not because we have genetics as a discipline. Also things like the Odyssey, you still find that it takes a long time, but I have to say it has improved from when my kids were being diagnosed to now. At least the healthcare system is not as, it has more information. Doctors, the younger doctors are more willing to listen to parents. They're more willing to do research when it comes to these rare diseases. So at least I think, in my opinion, the Odyssey is reducing with time. So I think that's a good thing. But in general, we're still far behind.
Yeah. Thank you. And Kelly, what's it like in South Africa?
Yeah, so I mean, I think we've come a long way. I think all the issues that have been highlighted by both Samuel and Christina exist, even in South Africa, who's, you know, from a medical perspective, seem to be deemed to be relatively advanced from an African continent perspective. I mean, we still have a complete underreporting of congenital disorders. We have very, very limited genetic services in place. But I think one of the highlights, what has largely improved the diagnostic odyssey for patients, has been patients being able to access support prior to a diagnosis. I think has really, really shortened the time frame, because patients, prior to the digital age, I think patients were largely driving their diagnosis themselves as well. And it was, you know, I think very, very often patients were going back or finding new doctors and saying, you know, I've heard about this, I've read about that, I've met someone with this, is this something that we should look into? I think patients having the ability now to connect with other patients on the possibility of them being diagnosed with a rare condition without necessarily knowing what that condition is, and patient storytelling and having that much more access to information, I think is probably doing a significant chunk of the work in terms of reducing that time frame. And I think also from our perspective as a patient organization group, our ability to be able to refer patients into tertiary services a lot quicker, as opposed to the patient having to wait on the system to refer them, has also really, really helped. But still, one of the biggest factors is our lack of diagnostic ability. You can have a very clear understanding of what you think the patient has. The inability to be able to confirm that diagnosis is still a critical factor, and the cost associated to out-of-country testing is huge. So I think until we've managed to upskill and develop our diagnostic services significantly, I still think that that's going to remain a challenge.
I remember hearing you speak at an event once where you said, and correct me if I'm wrong, that there's under a handful of geneticists serving the whole of South Africa. Is that still true?
Unfortunately, we don't have, and it's not for lack of trying on their part, right? Our training facilities are relatively good. We've got lots of individuals wanting to study genetic counseling as well as genetics. Unfortunately, our government hasn't mandated any posts for them. So they qualify and they've got nowhere to go, and we can't get them employed. And I think that that's where collective advocacy has been so important. And unfortunately, with the appearance of, and the kind of the HIV boom, for lack of an alternative phrase, but when that hit, we had relatively good genetic services up until that point from a population per capita perspective. But all the funding redirected to HIV and TB, and subsequent to that, it hasn't redirected. Now that that's settled, the funding hasn't redirected back into genetic services. So that is still a significant issue. I mean, in KZN, which is one of our provinces, we have one genetic counselor, one geneticist, and we've just had another genetic counselor appointed for 11 million people.
Wow, that's unbelievable. And I think when you hear people in the US and the UK saying they have to travel a few hours or across state to see a geneticist, and then you think 11 million to 1 it's unbelievable.
Yeah.
So we seem to have lost Samuel, so we're going to keep going and hope he can join us. I know that Wi-Fi is a struggle. So Christina, I'm going to come back to you. And so let's think past the point of diagnosis. Once people are lucky enough to get diagnosed, what is then the common experience? Is there local care and management set up? Do they have long-term protocols in Kenya? And is there the kind of mental health support there to go along with the physical care?
Sadly, no to almost all the questions, in the sense that, let me start with mental health. We are struggling as a country, even without the rare disease aspect. So when a caregiver or even a patient of a person living with a rare disease has a mental issue, first they will just treat the mental issue on its own. They will not catering the predisposing factors of the fact that this person has a rare disease, doesn't have enough support, doesn't have care. So it's like one big rabbit hole. Also things like, luckily we find that others are, guys, with the internet, guys are Googling for support groups. So once they know this is a rare disease, you find they go online and they look for a rare disease organization, and luckily they find us. So that has helped in the sense that you're getting referrals from different healthcare providers or even directly through online searching. And something else is on the diagnosis. I think we are better off than where we were before, and it's getting better with time. Yeah.
Thank you. Samuel, welcome back. We were just talking about when you think and look past the point of diagnosis and we think about management and care, and it would be really interesting from your perspective as a clinical psychologist about thinking about the bridge between mental health and the physical care, and is that there in place for people living with rare diseases, and is there long-term care and management in place once you do have that diagnosis?
Yes, thank you. Yeah, I mean, looking at way back from 2017, when we started our program to date, I would say that there has been a huge advancement in terms of care for persons living with rare diseases in Ghana. Where we have seen clinics start up in various hospitals, especially in various teaching hospitals. Now we are seeing new clinics being started in some regional hospitals, and we are seeing an increased interest by medical professionals in rare disease care and even information relating to rare diseases. In terms of the capacity to diagnose, we launched a diagnostic access program, and through that program now we are able to help with the diagnosis as well, in being able to make sure that the infrastructure to diagnose. And we are seeing that many requests are coming in day by day, patients reaching out to us, and we leading them to the right care and being able to direct them to the right resources that are available and being able to provide the diagnostics for them. We have labs across the world that are supporting our efforts to diagnose patients. And there are new labs locally coming up that are making direct investments in to be able to provide diagnosis. And there are labs here that have started commercializing tests for diagnosing rare diseases. And some labs have started including panels for rare disease diagnosis locally here. We are seeing that in terms of the treatment, though for many rare diseases, we do not have access to the therapies, that is the drugs that are available. We know they exist, but we cannot access them, many due to issues of cost and other logistics challenges that exist. But we also have seen that the FDA has published new guideline for registering of orphan products here in Ghana. And that is a huge step for us.
I think we may have lost them. Oh, are you back?
Yep.
You're cracking up a bit, Samuel, but thank you. That's very interesting. Your Wi-Fi disconnected slightly, so we lost the last bit, but thank you. That's really interesting and inspiring that things have improved so much since 2017. So I'm sure congratulations for all the hard work you're doing there, and thank you. Kelly, what's it like in South Africa when you think about management and care?
I think management and care is unfortunately still very fragmented. I think the African issues around, malaria, HIV, TB, I don't actually think very often other continents understand the impact on that from a resource perspective. I think that accessibility remains a struggle. Our regulations very, very far behind. We have often, South Africa particularly has very, very good regulations in place. However, it has become an inhibiting factor to some extent for orphan products, specifically because of the fact that I think our regulations haven't necessarily been designed with that in mind. So as a result of that, we're sitting with a bit of an issue in terms of accessibility, and that becomes very, very problematic. Outside of that, though, I think that one of the big things that we have managed to do is educate patients better. And because of the fact, just excuse me for 1 second. It's my dogs and they're playing with the dog food. I think one of the big issues in terms of the accessibility is with us educating patients better, patients have a much better understanding of what they should be expecting from their treatments. And I think that them being empowered in that regard has made the jobs of clinicians that much easier and given them the ability to focus on the difficulty that patients can't overcome. So I think patients really having that access to information and understanding, and also being somewhat pushy in terms of the expectations and them getting, global care, has really, really helped in advancing what is available to patients. But access to treatments based, particularly innovative products, is still really, really difficult and very, very fragmented in the South African context.
Thank you. And Christine, how's access to kind of drugs and trials and therapies where you are?
Almost minimal, zero, in the sense that even basic drugs that have not been approved by Pharmacy and Poisons Board, by the time they are getting here, the process of them being adopted through different pharmaceuticals is difficult and it takes long. So you find that access to treatment is hard. There are no clinical trials that are not advertised, but thought for in Kenya. And I don't know if that's the same with Ghana and South Africa, but you find that most of clinical trials that go around rare diseases are done in the West. And that doesn't mean that the results are the same for Africa. So you find that in Kenya, we don't get so much into clinical trials unless it's a disease-specific condition, and that individual has reached out to the global group to be enrolled into the clinical trial. Yeah.
Mm-hmm. Yeah, no, that's true. That makes sense. And Samuel touched on the work that he was doing, and that has kind of been happening since 2017. And we've had a lot about all the issues and barriers that you're all facing that I think from the West, it's hard to imagine, some of the things that you're dealing with. But what are your organizations? You've all done wonderful things by setting up these organizations to combat this. So from what is your kind of the heart of your mission and what you're doing to try and improve things? Samuel, we'll start with you. I know you touched on it briefly, but what would you say right now in a pandemic world with everything that we have against us all, and you with your own unique geographical barriers, what's your organization doing to try and improve things? Just ask you to unmute yourself, sorry.
Yes, thank you. Basically, our commitment is to improve the well-being, the quality of life of families living with rare diseases. And since we started in 2017, majority of our efforts have been in the area of being able to improve awareness and knowledge on rare diseases among various stakeholders. And we've done that through the Rare Disease Day campaigns, through symposiums, through workshops, through webinars, and through media engagement. And we've done that through, and including engagement with government leaders, heads of institutions, heads of agencies, talking directly with them in the need to prioritize or factor rare diseases in our system or in our planning for rare disease, other diseases. We need to think about rare diseases and be able to create a pathway for them. We've done that a lot, and we keep doing that through several engagements. And so we have an education training program which is targeted towards medical professionals now. And from next year, we are opening up to patient advocates and other stakeholders, including the media, to be able to empower and equip them in terms of what to do. We offer CPDs through these education programs, and so we have many of the professional bodies accrediting our training program for professional development, and so we have many clinicians joining me every time we have these trainings. And then we launched the Diagnostic Access Program, where we partner with so many labs to be able to help us offer diagnostics to our patients. And some of the labs, we've been able to subsidize the testing through our collaboration. For others too, they decided they are offering the testing for free. And we have these kind of collaborations going on with so many labs across the world. And so we're able to make the diagnosis easier locally here to be able to provide grants to paid families to be able to afford the imagings that needs to be done to be able to arrive at diagnosis. And so sometimes we even are able to get the care started before we finally get the treatment started, before we get the genetic test or the final molecular diagnosis to proceed from the next steps. And we have that through the diagnostic program. And recently we started pushing for newborn screening through the diagnostic program. And we are advancing in that area. Even yesterday, we enrolled our first patient on newborn screening. For newborn screening. Yesterday, we had our first patient who is getting newborn screening. And so in the area of care planning, care coordination, we realized that was also a challenge because many patients are receiving care in different facilities from different specialists, and many a time they are lost out in the system, or it becomes overwhelming. So we launched a care coordination program where we have social workers and psychology assistants and other healthcare team who have come together to help families navigate through the healthcare system. And through the care coordination, we have people who even go to the hospital with their family to help them get to the care in time and all. And so we launched a care coordination program. And then we realized the gap in data as well. And so we started making advancements and efforts in being able to bridge that gap in data. So we made efforts to launch, build a national registry with the help of one of the contacts that we got through being member of the Global Genes Foundation Alliance, which is PROS Foundation. We were able to start working towards building a national registry, and PROS Foundation has been very, very helpful to get us to this far. And we have now built the national registry. We are currently testing at the testing phase, and we are hoping that by the end of this year, we'll have rolled it out into actually collecting data. And we are so in the area of data, that is what we are also doing. And so I think that we've made a huge direct investment into the healthcare system, and I think that we've made a huge direct investment into the healthcare system because we are able to intervene at every stage of the care where we think there's going to be a challenge for the family. I forgot to add that we also have initiated a therapeutic access program where it is helping patients to get access to the therapies. And so we are currently seeking therapies for some patients with MPS disorders, and we are also enrolling other conditions. I think through that we able to link the Hemophilia Society to some resources that will help them to assess the factor in all of those. So we are also exploring options in terms of how we could make sure that every patient has access to the therapies if available in our or anywhere around the world. As soon as immediately the treatment is available, we'll be able to get it to the patient in time. And so these are some of the few initiatives we've put in place since we started in 2017, and we believe that with support we'll be able to help families get their care in time.
Yeah, I mean, that's hugely impressive. A hell of a lot of work done in a short space of time. Congratulations. That's amazing. Christine, what are your organization doing?
Okay, our objective is to create policies, help the government create policies and implement them around rare diseases, because right now the focus for the government is on communicable diseases and not NCDs. So just trying to change that narrative. Also trying to find a rare disease definition for our country. In the process, also creating a registry, a national registry, because there's none in the country for rare diseases. Creating awareness and reducing the stigma around rare diseases in the country. And also basically trying to create a strong community, a strong rare disease community in the country through engagement with the different stakeholders, pharmaceuticals, hospitals, patients, caregivers, name it. So just let's just say we're just trying to knit ourselves together as we try and figure out what else we can do more for our country.
Yeah, so important. And I believe it is an African proverb that if you want to go fast, go alone, and if you want to go far, go together. And I think you're all great examples of how important that is and what you're doing. Kelly, what are you guys doing in South Africa?
So, I mean, I think we were doing a lot, then COVID happened, and then we redirected, and now we're trying to find our feet in a post-COVID environment. So it's been quite interesting. But at the moment, we're really focused on trying to improve our data. We are in the process of developing a patient-driven registry. So kind of taking the responsibility away from our powers that be and our Department of Health, and trying to put it in the patient's hands so we can start getting some information together that we can use to improve our advocacy. And we're also very focused on policy development. We're in a bit of a times of change at the moment with the prospect of national health insurance being tabulated at the moment, and they're hoping to kick that off in the next sort of 2 years, which will obviously change a lot for our healthcare system. So we're very focused on trying to keep abreast of all of that. And then I think we've had a fundamental shift in how we're working with our patients. I think because of how we started initially, and it was really my own need to want to connect with other patients, I kind of took on a lot of responsibility in terms of assisting them on their journey. And we realized that we might have not done it the right way. So we have spent a lot of time over the last year and a bit to really try and empower our patients more, give them access to tools, and teach them to learn how to advocate for themselves as opposed to taking care of the advocacy work for them. And I think in that process, we've really strengthened, and we've managed to develop a group of about 100 patient ambassadors that have that have really gone on to strengthen our advocacy efforts. And it's been really, really exciting to see them develop, you know, as advocates in their own right and being able to help their own communities. And in doing so, also help other key priority healthcare areas, not necessarily rare diseases, but we're strengthening healthcare users across the board. And I think that will ultimately land up improving the system. I always say if you can change a policy to work for a rare disease patient, it will have positive impact on any other chronically ill patient because of the fact that we're so complex. So, you know, by developing stronger healthcare advocates, I think we are ultimately strengthening our systems, and we're starting to see the fruits of that at the moment.
Fantastic, amazing. And it's interesting, one thing that unites you always is the intent and priority of registries, and data is so powerful, and you see that across every region and every country in the world. And I'm so pleased that you're all working towards getting that kind of patient-driven data in. It's so, so valuable and so important in driving things forward. So we're amazingly almost coming to time, but I'd love to finish up with hearing from each of you. If you had that kind of genie in a bottle and you had one wish that you could grant for your rare disease community that you're working so hard for, what would it be? And Samuel, we'll start with you.
Yes, my wish is to see a country, Ghana, that is very, very sensitive to the needs of persons living with rare diseases and their challenges they go through as we set up our health system, as we set up our social systems, as we take decisions and make plans. We have in mind we have factored in how that affects persons living with rare diseases and make the necessary investment. It's a big dream to have, but I'm very, very optimistic that this is achievable. And we just have to continue to work together and continue to agree on at what step we go the journey together, basically. And with that, I am very sure we can get there. So I'm looking forward to a point where every person living with rare disease would get what they need in terms of care. And yeah, basically, that's what I'm looking for.
Thank you. It's a good wish. Christine.
For me, my wish is a comprehensive, efficient, effective, universal healthcare system for my country. Because if it's comprehensive, means it caters for people living with rare diseases. And that, I think, since we are like at the bottom of the barrel when it comes to healthcare, would have been catered for and our needs would have been met.
Yeah, so important. Thank you. Kelly.
It's such a tough question because my head says I would like for a corrupt-free healthcare system because that would free us up with a lot of resources. But as a human, I would say an empathetic healthcare system because I think empathy could drive a lot of change. And with enough empathy and understanding, I think you'd have the willingness and the desire to push things through. So if I had to pick one, I'd probably lean towards the empathy, but man, that corruption element's right up there.
Yeah, wow. I love how you put that, you know, empathy can drive so much. I think that's so true. And we underestimate that. I think people think about the big things, but it's so important for people to really get it and care and want to do more. So with that, thank you all. This has been so interesting to hear about the struggles you're facing, the barriers that you have, and the incredible work that you're doing to knock them all down and to help as many people impacted by rare diseases as possible in the countries that you live in. So thank you so much. We appreciate your time and wish you the best of luck with all of your hard work and efforts going forward. And I'm going to pass it now back to Parvati.
Thank you all to all our speakers, our panelists, Professor Bloom, for these amazing insights and for all the work that you do in your country and for the larger rare disease community. We truly are so thankful that you took time out of your busy schedules to join us for this panel to highlight to the world your successes, your pain points, and everything else in between. Please be sure to visit our evaluations tab under each section for the sessions that you have attended. We appreciate your feedback on the session and want to ensure that we are able to provide great content and programming for the rare disease community all around the world. We thank you all for your time and we hope you enjoy the rest of the summit. Thank you again.